Thank you, everybody, for joining the fourth action period call of the Injury Prevention Plus Safe Environment for Every Kid SEEK QI program. We are in the sixth wave, and we are happy to have you. We always want to thank our program partner, the Ohio Department of Health Violence and Injury Prevention section. So the agenda today will look similar to other calls. I want to welcome you, and then we'll hear from Zainab with data review. Lisa DeGeeter is back for this wave to give us an update on the Ohio Domestic Violence Network. And if we have time, QI Corner and next steps with me. So welcome. In the chat, if you could please share your name and your practice name if you are listening safely. And Zainab, I have your slides.
Thank you so much. I wanted to thank everybody for taking the time to submit their data, and for really making sure that your patients are using the iPad to submit data. So this data that we're going to see today is aggregate level. So this is all the data combined for all the practices that have submitted data. You'll receive your individual practice level data probably this week or next week. I know Brooke will share that with you. I'm ready for my first slide. So our first umbrella topic is social needs, and everyone's been doing great in terms of screening. So everyone that's receiving the screening is completing the entire screening tool. In terms of counseling, we're seeing higher rates of counseling for the older age group, the 13 months to 5 years. We are seeing a little bit of a decline in the younger age group in terms of counseling. Again, this is what it looks like for all of the practices combined. You'll receive your individual data and you'll be able to gauge how you're doing and see areas of opportunity based on what your individual data looks like. Next slide, please. In terms of family needs, we did a lot better for counseling. Again, with the screening, we're at about 100%. We had a few patients here and there that did not complete the entire screening tool. I think they answered the first question or two, and then they just left the rest blank. So that's where we're seeing 99% there. But in terms of counseling, we did see an increase in both age groups for family needs. Next slide, please. This is home safety. This is the largest portion of our survey. This asks questions about securing furniture, if the primary caregiver has CPR certification or is CPR trained. Again, we're seeing very high rates in terms of completing the screening tool. In terms of counseling, also, we saw an increase from February to March. So we're hovering at about 90%, a little bit less than 90% for both age groups here. Next slide, please. Car seat safety. Again, we're seeing high rates of screening in terms of counseling. The younger age group is at 100%. The older age group is at about 90. Next slide, please. Safe sleep. This one's only asked of the younger age group, the birth to 12 months. So we're seeing, again, almost perfect screenings. But in terms of counseling, we are seeing an increase, a gradual increase from January up through March. We're hoping to see that increase a little bit more, but great job there. Next slide, please. And this is the resources provided. You can tell us any kind of resource that you're giving them. I know that we as AAP provide resources to you, but if you have any resources that are specific to your practice and you're giving that to the patients, then please, make sure that you're documenting that correctly. But we're at about 75%, 78% for both age groups here. So doing pretty well compared to February, but hopefully we're trying to get that a little bit higher. The caregiver feedback survey. So this is the portion of the survey that the primary caregivers complete, and it asks questions about what they learned, if they're willing to make any changes based on any of the counseling that you've provided to them. And so we are seeing a little bit of a dip, but not really anything significant. So we saw a little bit of a decline in January to February, and then from February to March. But again, this is not anything that's reflecting on what you guys are doing. It's just based on them if they're willing to change or not. So 88% of the patient population that completed the survey said that they were willing to change on any of the needs that they had. And then the data tool completion rate, so the percentage of the total patient population who completed the screening tool is about 31%. So this means of the patient population that you're seeing, only about 30% are completing the screening tool. We're really hoping to get that to increase a little bit more. And again, this is why we're asking for those patient totals. I know sometimes there's a little bit of a delay there, but I think that everyone's been submitting theirs pretty regularly now. But this is just some back end information of why we're asking for that information or for that data. We're hoping to get you to have more or a higher percentage of your patient population fill out the survey. But again, we were doing a lot better in January than we are now in March. Next slide, please. This is the caregiver feedback survey. Again, this goes back to whether or not the patients are willing to change or their plan to change. So if for each need that they indicate, for each question that you're counseling them on, they are then asked whether or not they plan to make a change or whether or not they plan to make a change, right? So we are seeing very consistent numbers here. The majority, about 90%, are saying that they plan to make at least one change. And only about 10% are saying that they don't plan to make a change. Again, this could be for any of the questions. If they said that they are planning to change in at least one of them, then they are within the plan to change portion of the graph. Next slide, please. And this is a little bit more detail. So where are they in that changing process? What is the likelihood of their change? And then you can see here in March, about 50% are ready to make a change right now. And another 28% are seriously considering changing. So here we have about 80% that are willing to change and ready almost to make a change. A very small percentage of 4% have no thought of changing at all. Next slide, please. And then this is completed surveys by focus population. So we have our focus populations, which is our Medicaid group, our African American race, other race, and Hispanic ethnicity. And so these are not mutually exclusive. So they could be Medicaid holders and African American, or they could be Medicaid holders and Hispanic. But the majority of the people that are filling out the survey are Medicaid holders, over 50% since the beginning of QI. We are seeing very low numbers of Hispanic ethnicity, which makes sense because I think the Hispanic patient population that you have is pretty small anyway. Yeah, so this is just an overview of who's filling out the survey, what the percentage population of each or the distribution of each of these focused populations looks like. Next slide, please. And then here's the counseling rate. So for every need that they have, you either counsel them or you don't. Overall, the larger graph on the left is their for all of their needs, the injury needs and the social determinants of health needs. We are seeing that, again, we're seeing lower counseling rates overall in March than we did in February and January. But the highest, the patient or the focus population with the highest number of counseling or the highest rate of counseling is the Medicaid group, which makes sense because they make up the majority of, they make up a little bit over half of your patient population. And then that just automatically means that they are the ones with the most needs. In terms of injury and social determinants of health, for injury, the Hispanic population has the highest counseling rate per need. And then for the social determinants of health, we're seeing, again, the Medicaid population. These graphs are really meant to show you the counseling rates per each of these focus populations, right? So it can tell you a little bit more information about where there are needs and who is not getting their needs counseled. So for example, if we're seeing lower rates of counseling for African Americans, that means that just kind of gives you an idea of where your areas of opportunity are. So I'll focus a little bit more on when you have an African American patient come in to give them those resources that we're providing or any resources that you have, or making sure that they're counseled on the needs that they have. I think this is the end of my slides. If anyone has questions, please go ahead and ask, or you can put them in the chat. If any questions do come up later, please let me know. We can definitely get those questions answered for you. If not now, then whenever you ask.
Thank you, Zainab. Any data questions from the group? Okay, and as Zainab mentioned, I will get your individual data slides to you. My plan is this Friday. And then any questions that you have, we can talk on another call. We can talk via email too. So Zainab, thank you so much.
Thank you.
Okay, Lisa, I can stop sharing.
All right, and I am going to apologize, gang. I have been on Zoom meetings since like 8:30 this morning, back to back to back to back, and my camera is apparently sick of me. Because no matter what I do, it will not bring the picture up. But I am going to share my screen. And is there anything you need to give people as background?
Maybe a little bit. They have access to the links that you mentioned in your PowerPoint. And we have some repeat providers that were in wave 5, now we're in wave 6, but the majority of our providers are new to the group.
Wonderful. Okay. So some of you, I'm going to apologize because you're going to have heard this before. It's a lot of the same content with some updated material about changes over the year, because what I want to do is give people some background information about DV, what you may or may not be seeing, and what local programs can do. I think the SEEK program is a fabulous thing. I used to be a Child Advocacy Center director before I came to ODVN, so I don't know if I've shared that with folks before. So I am familiar with the SEEK model, and I think it's fantastic that folks are doing this. And just want to give you some information for some other things, and that's why we talk about it in terms of DV 101 and what ODVN can do, so that you've got resources in your community in the hopes that we can collaborate more. So we start usually with a social definition of DV, and we want to make sure that people realize, and I apologize, we got a little tutti frutti with the slides. There we go. That should be everything. When people think about domestic violence, the standard picture that's kind of in folks' heads is, the classical image of a battered woman, someone who's been punched, black eye, those kind of things. But the reality is DV is much more than that. It's a pattern of coercive and controlling behaviors. It's about exercising power over somebody else. And it certainly can include physical violence, but it also includes sexual and psychological violence, economic and other forms of coercion. And it is something that we see both adults use against their partners, and in many instances, we also see adolescents. Violence frequently starts in teen dating relationships, and it escalates in teen relationships. We'll get towards the end to talk about our fatality report, and we certainly see teen perpetrators of that kind of crime and victims as well. So we're really looking at a bigger pattern of behavior. And so I'm going to be honest, I'm breaking all the rules of PowerPoints right now, but I appreciate this image, and I've got a few more embedded in here because I'm assuming Brooke will be sending this out to all of you. And part of my goal is for you to have resources in hand if you need to look something up, because usually the rule with PowerPoints is no more than 6 lines, no more than 6 words, so that people can actually look at the content that's up there. And this clearly breaks that, but it gives you some of the types of tactics, some of the things that survivors of intimate partner abuse experience in terms of intimidation, isolation, economic abuse. That comes up repeatedly with folks. And I'm keying in on that a little bit because I heard your data talk about how many people use Medicaid that you're seeing in your SEEK clinics. So choices, when your economic choices are limited, your behavioral choices end up being limited in terms of how you address the things you're experiencing. So looking at those kind of issues, threats, intimidation, manipulating children, those are all things that people need to be aware of as you're working with kids and families. So things that are worth really, in terms of signs, because survivors we know often don't disclose. And if you're doing SEEK, you are child abuse professionals. And so I'm going to say what the child abuse folks say over and over: disclosure is a process. It's not an event. People So much like when we talk about child abuse, it's very similar for adults. How much can I share? What can I share? Who can I share it with that will help me become safer, help my child, my family be safer, versus what if I share it is going to in turn get used against me? So looking for things like isolation and a lack of support system. So as you're working with families, it's not, and I know you guys are medical professionals, you know these things in terms of how to ask questions, but we always put these into training. It's not, so do you lack a support system? But who can you turn to if this? Who helps you with that? Do you have alternative childcare? If you needed this, that, or the other, depending upon the situation, who could you rely on to start to assess whether or not someone is isolated or doesn't have what they need? And again, because you're child abuse pediatricians, I know you know risk factors for violence. And when we couple DV with child abuse, we know that isolated parents are at a much, the children, when parents are isolated, are at a much higher risk for experiencing violence. Canceling appointments, that one, I know that's phenomenally frustrating. It's frustrating in court systems. It's frustrating for you guys. It's frustrating for us when we deal with survivors. But folks who are dealing with violence in the home don't have a ton of control over their schedules. And when you think about it, that makes some degree of sense, unfortunately. But people, when you see those cancellations, there is often a reason behind it. I'm forever telling folks that behavior, all behavior, is communication. And sometimes not showing up is a function of, I'm injured and I don't want to have to answer questions about how I sustained the injury. The child is injured and I don't want to have to explain how the child sustained the injury. I know that the cover story I'm going to give, people are going to be able to pick apart because I've been there before. Or I don't think I can afford it, or someone has hidden the medical card because they're worried what I'm going to tell a medical provider. Folks know medical providers are mandatory reporters. Folks are starting, one thing I can update from last year that we know, because strangulation for a couple years now has been a felony. Ohio was the last state in the union to make felony strangulation, strangulation a standalone felony. And you guys have an obligation, just like gunshots and stabbings and burns, if somebody's coming in for care, to report injuries that are a result of felony conduct. So we are now seeing survivors who don't come in for the medical care that they personally need as a result of having been strangled, because they are worried that that will be reported and just make their offender more angry and escalate the violence that they're experiencing. So there's a ton of reasons why people do that. It doesn't make it any less frustrating, but it's good to know those things in the background. People checking in, minimizing concerns, not being able to explain the same kind of things that you've learned about with child abuse are very, very similar with folks who are in violent relationships with their intimate partners or with the child's other parent. So look across the family is really the summing that up. The other thing that I wanted to drop in here, just so that you had it, is what the criminal law definition is. Because when we looked at that social definition, we looked at that coercive control and the fact that there's a lot of different types of violence that constitute domestic violence when families are in these situations. The criminal statute, however, looks at causing physical harm, recklessly causing serious physical harm, using force to cause somebody to believe that they will be at risk for imminent physical harm. So it's all about the battering when we look at criminal conduct. Because I know one of the things that we see as well, or what people sometimes question, is why don't people make police reports? Why don't people get orders of protection? And there's a lot of good reasons why people don't do that. And it's in large part because batterers, offenders use the level of violence necessary to obtain the amount of control that they're looking to have over the other person. If I only have to hit you once and then use a threat of doing it over and over and over again without ever laying a finger on you, that's not enough. Even though you've got that believing the offender will cause imminent physical harm, that's a really difficult thing to prove. So people know that they don't always get the recourse, they don't get the remedy, they don't get the protection that they get when they make law enforcement response reports or when they attempt to get an order of protection. So I think sometimes we look for those things to validate or verify, and they're not often there. And often when they're not there, it's for a very good reason. So I hope that makes sense. And I don't think I said this at the beginning, but I've got enough content. And heaven help you, I train for a lot of different organizations. I could talk for a day and a half, and I don't want to do that to you. And I tend to be very informal. So if somebody has a question, please feel free to come off mute and stop me, because I'm happy to respond to anything if you're seeing anything or having any concerns that you'd like to talk about specifically. But we really see people not necessarily rely on the criminal justice system because it does not provide what they need in order to keep themselves safe. So that's, I think, worth knowing when you treat people, that they may not be availing themselves of systems that you think they might, or they may not use some of those referrals you make. And I know what you're tracking tends to be more around counseling and other types of follow-up. But sometimes people just don't take that advice because they already have some experience that would contradict it. So just a little background on ODVN as well. We are Ohio's federally designated DV coalition, and we do a lot of training, a lot of different folks, not just to our 76 member programs. So that, I think, is something useful for folks to know. 76 programs across the state covering all 88 counties. 57 of them are shelters. 19 of them are not, because I think when people think about DV services, they usually think shelter, and that is certainly the majority of them. But we also have standalone programs that do a lot of other resources, help people get into apartments safely. We have culturally specific organizations, people who deal with violence in immigrant populations. So we do have some programs that don't also include the provision of shelter. We do a lot of prevention work, public awareness, technical assistance. And what I am is the Senior Director for Policy and Prevention. So I am often testifying at the State House. We're looking at bills and how things will impact the folks that we are serving and that our member program agencies are serving. So we are at the moment, and all of you know this, federal funding is in many ways in flux. And we are funded at the moment. We can provide emergency hotel stays, relocation assistance, housing, legal assistance. We actually at ODVN do provide some direct services. We can help folks get connected to attorneys. We've got a panel of attorneys that we pay what's called a low bono rate. It's not pro bono. The attorneys aren't volunteering, but they take a reduced rate to work with survivors. And these are all things that at the moment, and we believe through September 30th, the end of the federal fiscal year, will all be in place. I think it's anybody's guess what October may look like in terms of some of these pieces of funding. And I have absolutely no doubt with Medicaid and Medicare and other fundings that you all are familiar with that as well. But at the moment, we have the abilities to help people get out of situations and potentially get some assistance in using the legal system to redress things so that people can become more independent. So the next slide I have, I'm going to click through it. It's a video, Allstate put it together, and it's about economic abuse. But because we do have limited time, like I said, I'm assuming Brooke is going to send this to folks, so you can take a peek at that if you want. But in terms of financial abuse, I think one of the really important things to realize, because a question we often hear is, why doesn't she leave? And I know if you are doing Seek, one of the things you see is a parent who's getting in trouble with the child welfare system for quote unquote failure to protect. And I'm going to be honest, that is something that drives me out of my gourd. Because if you really finish that sentence, the question is failure to protect from whom? And it's usually the other parent. But in a case where a parent is alleged to fail to protect a child, what usually happens is child welfare then places the child with the other parent. So think that through for a second. I said what I meant, and I meant what I said. One parent is abusive, the other parent is failing to protect from the abuser. So child welfare's answer to that is to place the child with the abusive parent. And if you are thinking that makes absolutely no sense, I wholeheartedly agree. But we watch them do it over and over and over again. And failure to protect is often a function of money. Allstate, and again, I think, and I know because you guys have science backgrounds, you appreciate data. One of my favorite quotes is from Mark Twain. There are 3 types of lies: lies, damn lies, and statistics. That said, the percentage, when Allstate looks at these things, 94 to 99% of people don't leave their situations because there is financial abuse going on. They can't afford to leave in a way that would let them keep themselves and their children safe. And this isn't ODVN data. This isn't the National Network to End DV's data. This is information coming from a bank, from an insurance company. So they are looking at things a little differently. So for as much as I say, you know, lies, damn lies, and statistics, they're looking at things from a different angle, and it does not help them, this kind of number, to know that there's this level of a problem. So I think that we've got some reliability with this number because of who's put it together and how they've put it together. So the choices that people make, sometimes, I'm forever telling folks this, if you are working with someone and the choice they're making, the behavior they're engaging in, doesn't make sense to you, the problem probably is that you don't have all the information. Because if you understood their situation completely, their behavior would make a whole lot more sense. And I know we deal with some folks that are not always the sharpest, the brightest. I know we're dealing with people who are traumatized, and that impacts the way people process things and folks' behavior. But the reality is, if we had complete pictures, we'd have way better appreciation for why people are engaging in some of the things they're engaging in. The other thing to realize that it's incredibly important to think about in terms of abuse is that we think if people left, that solves the problem. If they're not together anymore, everything's good now, right? Could not be more incorrect. We deal with many, many folks who, even though the marriage is over, the relationship is over, they've separated, that's when the abuse escalates. We know that leaving a relationship is actually the most dangerous time for a survivor. Because again, it goes back to what we talked about in the beginning with patterns of coercive control and wanting that power over someone else. When a survivor makes a decision to leave, the offender experiences that as a real loss of control and loss of power. And often the tactics they use increase in frequency and increase in severity. So we see more physical harm and threats of physical harm. It is actually the most lethal time frame, the first few months after leaving, for folks, because if it's one of those, if I can't have you, no one will. So we do see escalated lethal violence in those situations. We see people use the legal system to try and get custody, to evade child support, to file civil suits against people. We're working with folks who, because they've gone in and filed a police report, their offender is suing them because you've gone in and said all these terrible things about me. And the survivor has gone in and told law enforcement the truth. And they're actually then being sued and trying to defend defamation suits, which sounds crazy, but we see it all the time. And at some point in time, when the systems don't coordinate and the processes can be crazy making, survivors who are in the middle of some of this chaos and systems that work at cross purposes sometimes don't always come across as credible or coherent, which gives the offender a whole lot more control in the situation. One of the resources that I'd like to share with folks around stalking and harassment, there is a Spark Center, sparc.org. And if you Google that, tons of resources on stalking and harassment. Stalking is frequently something we see as people leave relationships. And it sounds crazy. I think he's here. I think he's there. How does someone know information? We just passed a bill in Ohio in December that became effective in the middle of March, because bills in Ohio become effective 90 days after the governor signs them. So even though the legislature got done in November, the governor signed it a few days later, and it was mid-March when the law became effective. It was Senate Bill 100 in the last General Assembly, and it is about stalking and tracking devices. So putting an air tag on somebody's car without their knowledge, dropping it in a purse or a diaper bag or a tote bag, putting spyware, malware on people's phones or on their laptops so that you can hear or track somebody's behavior, that is now an independent crime in Ohio. And that is important to know. And that's important for folks like you to know, because the general public doesn't realize this yet. And stalking as a crime, and I'm going to apologize because y'all went to med school for a reason and you don't necessarily want the nickel lesson in law school. But stalking as a crime is something that we call a pattern offense. Most crimes have an actus reus and a mens rea, the guilty act and a culpable mental state. Well, stalking, if it's a pattern offense, it means that guilty act, the thing you do that you shouldn't be doing that's criminal, you have to do more than once. So that makes stalking much more difficult for prosecutors to prove, because it's not enough to show that the behavior somebody shouldn't have engaged in happened one time. It has to happen at least twice, if not 3 or 4 times. So it's a lot more evidence. It's a lot more witnesses. It's a way harder lift for prosecutors to get that done. And what has happened with SB 100, the stalking bill, the tracking bill, tracking device, is that simply the placement of something like an ear tag or a tile or another gizmo like that, or uploading software or downloading software that will allow you to track someone, is in and of itself an offense. Whether you ever turn it on, whether you ever use it, whether you ever show up and intercept a survivor somewhere, none of that matters. What SB 100 did was create a new offense around the placement of these devices or the software that is in and of itself criminally actionable. So if people aren't aware of that, that is something important to again. And I know I said it with protection orders and whatnot, we don't always send people to police. People sometimes don't think that the police are going to help. But if someone has found a tile or an air tag or I don't know how this app got on my phone kind of thing, that is something to let them know it's reportable, it's actionable, something can be done about that. So we've already talked about financial control, controlling the narrative, all these kind of things, whether it's in your offices, whether it's in attorneys' offices, whether it's in court. Abusers want to be seen as not being abusive, of being the reasonable one, of being making the other person look like they're overreacting. So listening with that kind of ear towards what survivors are saying, or telling you, sometimes helps, because sometimes it doesn't make sense. I think what sometimes we hear survivors say, and every survivor is different. All the situations are different, but realizing that sometimes the responses we get from people that don't make sense, or don't make sense, they seem contextually like they're incongruent. It's because somebody else is trying to present information specifically to have that effect. And the last thing on this particular slide is looking at how offenders try and control relationships with children. They try and control how the child perceives them. They try and control how the child perceives the protective parent. And so talking to kids can't always cut through that. And I know with SEEK, and many of you probably work with CACs and are familiar with forensic interviews, understanding child development and what kids are able to communicate, they're not always able to slice through the motivations as to why they're hearing some of the things they're hearing. And I don't ever want to be somebody who says, don't pay attention to what a kid says. I think 110% of the time we should be doing more listening to children to understand what is going on. But it's important that we think critically about what they're telling us, because they can't always unpack these things, if that makes some degree of sense for folks. So again, talking about things that survivors may experience, they can, all the things, I'm not going to rehearse this whole slide, but lots of things that make them difficult to communicate with, that make the information that they share with us seem not reliable, is often a function of the trauma they've experienced. And I'm going to guess, because you've done SEEK, you've had some trauma training, but you all know that trauma memories are not encoded, stored, or retrieved the way other memories are. So you don't get linear narratives about traumatic events. They tend to be very sense-based, but that's probably things that you're all familiar with. So it takes a lot of patience and a lot of piecing things together to really get a coherent narrative about what's going on in a home with a kid and a family from someone who has experienced abuse. And so this is a slide I usually throw in when we're talking to medical folks, because not everybody else will key in on this, but and the CDC still has some of their information around ACEs and those things up. But we know women who've experienced intimate partner violence, 80% more likely to have a stroke. We're looking at higher risks for heart disease, asthma, drinking alcohol. The assumption of unsafe or health risky behavior when people are traumatized, we watch those things happen. So even if you don't have a childhood history of abuse, if as an adult you have a history of trauma and experiencing domestic violence, we still see these kind of health outcomes for folks. So again, this data comes from the CDC, and the CDC's website has undergone some significant revisions in the past 3 or 4 months. And some of the data that used to be there is no longer there. But some of us who work regularly with this prevention and violence data knew that this was an area that was likely going to be targeted for revisions by the current administration. So we have at ODVN actually gone through and saved a ton of reports and data sources. So if there's something that you have looked at in the past on the CDC website, like the Youth Behavior Risk Survey is now gone. But if there's something you've used in the past that you go back to the CDC website and it is not there, please feel free to contact me, because I have a data guy who downloaded 10 tons of stuff that if people need it, we are happy to share it. So just want to let you know that we have the ability to do that as well. And so what do we do when we have survivors? And you guys are pediatricians, and I know that you're working with the kiddos, but kids don't exist in isolation. They exist in the context of these families, and supporting survivors and helping folks who are trying to protect their kids. And it's not easy. If you're struggling to protect yourself, it's certainly going to be a hard job to try and protect the kids as well. And punishing folks doesn't make anybody safer. So realizing that survivors are experts on their lives, we know that folks tend to downplay what they've experienced. It's okay, I'm all right, it wasn't that bad, it was a mistake, it won't happen again. All those things that you hear, we know folks downplay things up until the point that they realize the violence is more likely to become lethal. So if anybody's saying they're not doing something because they're really worried they're going to get shot, he said he's going to kill me, those kind of things, I think it's often as professionals, or at least occasionally as professionals, we wonder if people are overreacting. And when they do a little bit of research around that, we find out no. When people are expressing concerns around lethal violence, it's usually, if you did a lethal risk assessment on them, they would be definitely having elevated risk. So when people start sharing those concerns, sharing resources is incredibly important. You guys, as medical professionals, medical and mental health folks, get this because of HIPAA, but conversations in private spaces makes all the difference. Some of the allied professionals we work with don't always have an appreciation for that. But people do not disclose if they don't know who all's overhearing and what might happen as a result. We're forever telling people to document what they're seeing, not what they're thinking. If you can document bruises, if you can document injuries, if you can document statements, that's very different than I think there's DV going on. I train guardians ad litem as well. And what you think is so much less important than what you can see, because if you're going to have to explain it to somebody, whether it's in a child welfare system or law enforcement or a court system, whether that's criminal or juvenile or civil, being able to explain what led you to conclusions is what's critically important. We've already talked about the fact that disclosure is an important process, and that is true for adults as well as kids. And so forcing a response is probably not going to get you accurate information. People are giving as much as they feel safe giving, and it's really important to realize that. If you do have mandatory reporting obligations, and you do around things like strangulation or shootings or stabbings, and you know all this better than I do, but if you've got those, and you certainly do, disclose those early. And then it goes back to don't force a response. I want information about whatever, but if you give me accurate information, I may have to report it to a system that metes out a consequence to the victim rather than to the offender. So they're doing that calculation. Excuse me, maybe not in those words or that way, but they are thinking about, if I share this, then what happens? What's the consequence? So let people know about those things, provide resources and connections, which is one of the reasons I think SEEK is a phenomenal program, because it gets people connected to more options that are out in communities for folks. And yeah, so the other things to think about when you talk about folks, all those kind of things. And again, you're medical professionals, so I know you get this as well, but I understand, I know how you feel. No, we don't. If we're not in their shoes, and everybody's situation is different. You know, have you ever told somebody to calm down and had them calm down? We all know the only thing that does is escalate the tension. Those kind, and excuse me, I can only help if you're honest with me. Oh, that shuts people down so fast isn't funny. If I have to tell you nothing, the whole truth and nothing but the truth, then I've got to disclose things that I might not think you're ready to hear. That will definitely shut down a conversation. So thanking them for what they can do, letting them know you appreciate it, all of those kind of things, and using their language. You may document in more clinical terminology, but if somebody tells you they were smacked upside the head, you know, I wouldn't say, I'm so sorry that you were struck in your head. I would use, you know, I'm so sorry he smacked you upside the head. And that sounds so odd to give that as a suggestion for talking to people. I realize that sounds kind of strange, but it is important because it helps validate the survivor knows you heard them and that you're understanding them. So that can be incredibly important for them. So part of what we hear, and again, I'm breaking the rules of PowerPoint here, lots and lots of data. And this is 2023 information because the National Network to End Domestic Violence every year picks a day in September and just does a snapshot. How many people in every program in every state received what kind of thing, what kind of service, and how many people, how many requests for services came in that people could not meet. And so what I want to pull out on this data, well, and actually, let me back it up. So this was September 6th of 2023. So it happened in September of 2024, but we don't have the data yet. It takes them about 6 months to crunch it for all 50 states and 6 territories. So it'll be June before we get the updated data. So 23 is the most recent we have. And the number that I think on this that is striking is 404 requests could not be met because our programs didn't have the resources. So I very much appreciate that you guys make referrals lots of places, and it is something we struggle with. It's a part of why ODVN has the hotel program, why we do the relocation program, why we do some of the things we do, because we know our programs can't always meet the need, and we're trying to gap fill around the state as things pop up in different areas. And if you'd like more information on this, the NNED point in time study. It is actually, ODVN has a section on our website called Reports and Fact Sheets, and the full content is there if it's useful for anybody. The other thing that I would like folks to be aware of or know about is that there's another website out there, and it was created by the Linking Systems of Care for Ohio's Youth Federal Demonstration Grant, but the website is ohioheals.org. I'm actually going to pop up to the next one. And this fits in very well with SEEK. It's about how do we identify victimized children? How can we make no wrong door? How do we make sure we're linking kids to quality resources and do that across the state and across systems? So the website address is there for Ohio Heals on the website. And this is just a screenshot of the first page. It was a project between ODVN, the AG's office, Ronald McDonald House, which has a great navigator tool for resources, and Case Western. But there are tabs up there. About LaScoy talks about the people in the project. There's 6 of us. Our moms are proud. That is not the world's most interesting tab, but the For Victims tab has all sorts of resources that can be shared with families. The For Professionals tab has research papers, studies that were done by Case around what victim services providers are doing where in the state, training resources, lots of different things there. And this website just hangs out there. Unfortunately, I don't believe we get a ton of hits on it. But there's a ton of resources out there that everybody's welcome to use. And the thing that I'd really like to take a look at, oops, I think I went one too far, is one of the tabs is about a resource directory. And if you go in there, it gives you hotlines, chat lines, text lines, a database into trauma-based counseling. So you talk about what the type of violence is, what the age of the kid is, what kind of treatment modality you're looking for in what community. And part of what it shows is how lacking many communities are in these resources. But if something is there, it should pull it up. There are resources, a matrix of organizations that help people meet basic needs, all the state level crime victim services, legal services for victims. And then the last thing that is in this resource directory are the county resource guides. And so if you click on the resource directory and you hit You click on the button for hotlines, chat lines, and text lines. You get this drop-down menu, and the bottom thing is resources by county. And if you click that, it pops up links to all 88 counties, and it will take you to the county's website and either the county seat or the Wikipedia on the county. It will take you to census data on the county. It will take you to a link that helps you find local officials, local elected officials, who your state reps and state senators and members of Congress are. And then the sheet breaks into 6 color-coded Tutti Frutti boxes. Every law enforcement jurisdiction in that county, a link to their website is there. Every prosecutor's office, court, legal aid office, or provider of free legal services, click and there's a link to it. Everything in the pink box, whether it's domestic violence, rape crisis services, child advocacy centers, chapters of Mothers Against Drunk Driving, whatever the case may be, parents, of homicide victims, POMC, parents of murdered children, all of those kind of victim services, whatever the county has is there. Medical resources and hospitals are in the green box. Again, links to pages. Resources for kids and families, so child welfare, if there's a CASA program, if there are, the Family and Children First Council, the trauma resources, because OMAS has divided the state into like a dozen regions. And so the regional resource for the county for trauma-informed care is there. All of that is in the resources for kids and families. Child support resources are there, because again, that makes a difference. And that's a place where we see families fight, and it impacts that financial control. All these things kind of knit back together. And then the last box for them is the gray box, is all of the public school districts in the county. So if you need community resources, if you're training other docs or nurses or residents or whatever, you can print them. And it'll give you a nice tutti frutti looking laundry list of what's all out there. But if you're on it electronically, everything can be clicked and take you to those places as well. So I always love to let people know that that's out there, because once people find it, I think they find it very, very useful and helpful. And I did it again. So one of the other things ODVN does is prevention programming. So we currently do have a grant for Delta Ahead, and AHEAD is an acronym for Addressing Health Equities and Disparities. And we are funded through the end of the federal fiscal year. And we do all the work that's up there on the screen. However, our understanding is that it is one of the things that's being targeted to be eliminated in the next budget. So even though it was a 5-year project and should be running through 2028, we suspect it's going to unfortunately disappear in the fall. We are going to continue to do OMAN, is the Ohio Men's Action Network. And you guys get this again as a child abuse group. You understand, we don't ask kids to prevent violence. We don't ask victims of violence to prevent the violence against them. So OMAN is a group about healthy masculinity and positive fatherhood and trying to promote positive, healthy relationships. So we do have fatherhood grants. We're working with campuses. We're doing a lot of coaching and things. And actually, I'll pull this up. One of the things OMAN does is the new playbook about healthy masculinity, and we're on community college campuses all over the state doing training with their football teams and athletic departments. So there's resources there, and if any of these kind of resources that we have or trainings we have the ability to provide would be useful for any of your organizations, just let me know, because we can get you plugged in there and get you any of the resources that would be helpful for you. Happy to do that. We also do a lot of policy work. And because it is the spring of an odd numbered year, and Ohio does a biennial budget, so a 2-year period. So it starts July 1st of odd numbered years and runs through June 30th of the subsequent odd numbered year. So it'll start July 1st of 2025 and run through June 30th of 2027, the next budget. And so we asked to be in the budget of 40 million and we got put in at 20. We were in at 20 last time around, so we didn't get a decrease. We just didn't get the increase we were asking for. We're in the House budget. We hope to stay in the Senate budget. The Attorney General's office and the governor both had us in their budgets. So that's what we're using to provide these services across the state. And unfortunately, we're expecting hits to many federal funding programs as the next year or two rolls out. So unfortunately, that 404 in the slide about turning people away, we're very concerned that that's going to increase. But we're doing everything we can with everything we've got. A big part of what we do is try and stop things from getting to a level of fatal violence. And our other big priority, the fatalities is on the criminal side, and enhancing child safety is on the civil side, because we want to make family court processes, child support processes more equitable and make sure survivors' voices are heard and the courts aren't used to further extend control over folks. So those are the things that we're focusing on in terms of legislation. There's a link there to our fatality report. The thing to know is nobody's really tracking this data. We run 14 different media aggregators to pull reports of fatalities in from all over the state. So what you can see is Franklin County is clearly the highest. Stark hit a real issue. And part of the problem is I think there were 2 family annihilation cases last year, and one of those was in Stark County. So 5 of those, each of those dots represents a person, and all 3 kids and 2 of the adult dots were a family, a mom, a dad, and 3 kids, or dad killed mom, killed all 3 kids, and killed himself. Cuyahoga, you'll notice, for as many dots as are up there, given their population, they've been doing a whole lot with their law enforcement to look at lethality assessments. And last year they had almost twice as many. So what they are doing is working. So that's a good thing to know. But October is Domestic Violence Awareness Month. So we track this information consistent with the state fiscal year. So that July 1 to June 30. And in October, we do an event and release the fatality report. And so if you click that link, that will take you to that as well. This is just a list of some of the service areas. We are working with OSU, doing a lot of work around traumatic brain injuries. Most people are familiar with that. We do that with child athletes if they've had concussions from things they've sustained, but we know DV victims have all sorts of traumatic brain injuries, and that some of that goes back to strangulation. 83%, the last time we surveyed our programs, our residential programs, 83% of the people coming in from for shelter had experienced at least one, if not more, incidents of strangulation. So there are potential traumatic brain injuries in the background there. So we want to do DV forensic exams. Y'all probably are very well familiar with kits, rape collection, evidence collection kits. We would love to see something similar happen for DV survivors. Just lots of work around making sure people can access things. This is all my contact information. And again, I think Brooke is sending it out, and I think I've got I think the whole meeting's got a minute and a half left. But if anybody has any questions about anything, I am more than happy to talk to folks and plug you into anything at all that would be helpful. Thank you.
Lisa, thank you so much. Lots of good information. And yes, I will share. And I also put some links into the chat, but I will also share those again in the Friday email. Any questions from the group? Anything specific that your patients and families have been talking to you about that you want to run by Lisa? You can also do it offline too. Okay. Lisa, if I hear from anyone, I will let you know. There's your camera. I want to quickly share my last slide, if you don't mind, please.
Sure. It's telling me I'm not sharing. Are you able to?
Can you see it? Okay, great. Real quick, next steps. So we will be collecting SEEK data through May and the beginning of June. We will slowly start to send out some program wrap-up pieces and some sustainability things and some exit interviews toward the end of June. The monthly patient totals for your April total will be due the week of May 5th, and then the next action period call number 5 will be May 13th at noon. Thank you, everybody, for joining today. Lisa, thank you so much for educating us today. Everyone, have a good week. Talk soon.